Welcome, and thank you for joining us today. My name is Amy Powell. I've been active in the Pheo community since my mother's diagnosis in 2014. 3 generations of my family are known to have been affected by an inherited SDHB mutation, and I worked as a caregiver for my mother and brother, both of whom have since passed. I know many of you through my work through the my work with the Pheo Project, the Pheo Paratroopers, and the Pheo Alliance. I'm pleased to note today that I recently rejoined the Alliance as Community Engagement Specialist. I'm happy to be here today with Dr. Neil Patel, and we will provide a proper introduction in a few minutes. This program is brought to you by the Pheo Alliance, whose mission is to empower patients with pheochromocytoma and paraganglioma, their families, and medical professionals through advocacy, education, and a global community of support, while helping to advance research that accelerates treatments and cures. We'd like to extend a special thanks to Progenics for making this webinar series possible through an educational grant. Before we begin, we'd like to make you aware of some upcoming events. From May 9th through May 22nd, we'll be wrapping up our virtual fitness challenge, which is a fundraiser for the Pheo Alliance. The SNMMI Patient Education Day in Vancouver, British Columbia is happening on June 12th, and our Portland Regional Conference will be on June 26th. Finally, the last week of August is our Awareness Week and Virtual Patient Conference. Registration for the conference will be open soon. A reminder about today's format. Dr. Patel will present for about 30 minutes, and then we'll take questions and answers from the community. We'll ask questions submitted beforehand, and you can also type your questions into the chat section. We will do our best to have all of your questions answered if time allows. Many people will ask variations of the same question, so listen carefully for questions that are similar. Questions that are less case-specific are appreciated. Finally, we want to note that the information presented in this webinar is for educational purposes only and should not substitute for the advice of your doctor and medical team because they have in-depth knowledge of your medical history and current situation. Now it's my pleasure to introduce today's presenter. Neil S. Patel, MD, is an assistant professor of neurotology and skull-base surgery within the Division of Otolaryngology, head and neck surgery, at the University of Utah in Salt Lake City, Utah. Dr. Patel completed both his fellowship in otology/neurotology and skull-base surgery and his residency training in otolaryngology at the Mayo Clinic in Rochester, Minnesota. One of his primary research interests is the management of head and neck paragangliomas, specifically glomus jugular tumors. Several of his over 50 peer-reviewed publications are focused on outcomes following the treatment of jugular paragangliomas. As a lateral skull-base surgeon, he is actively involved in the multimodality treatment of skull-base and neck paragangliomas as part of a multidisciplinary team at University of Utah, a Pheo Alliance Center of Excellence. Most recently, Dr. Patel joined the Pheo Alliance Medical Advisory Board. Dr. Patel, welcome.
Thanks so much for that introduction, Amy. It's an honor to be here and to speak with all of you, and I'm looking forward to our session today. I'm going to go ahead and share my screen here. Amy, does that look okay to you?
Yes.
Okay, great. Well, again, good afternoon. And today for about 30 minutes, we'll talk about the management of skull-base paragangliomas. Some of you may be familiar with this through your own experiences or that of a family member. And I'm looking forward to our question and answer afterward. I have no relevant financial disclosures. As Amy mentioned, I am on the Pheo Alliance Medical Advisory Board. And again, I'm very thankful for the opportunity to present to you all today. And as Amy also mentioned, I practice at University of Utah Health in Salt Lake City, which was the first international center of excellence based on the Pheo Alliance Center of Excellence program. And we're really quite humbled to have that designation and really look forward to continuing the long legacy we've had of treating patients with sporadic and familial pheochromocytomas and paragangliomas going forward. So when talking about skull-based paragangliomas, it's really important to recognize the classic approach that we've used as surgeons for years, and all of these descriptions were long before my time, by Ugo Fisch, who wrote this chapter in 1978 of how to approach this very difficult to approach anatomic area called the infratemporal fossa. And this is the primary location where a jugular paraganglioma or glomus jugulare tumor and glomus vagali or vagal paraganglioma tumors tend to reside. And while these photos and depictions are seem to pretend quite an aggressive operation or a very invasive operation, this is the sort of classically taught approach as to how to get to this location and what important structures are involved in the management of these tumors. And while some of this is still true today, a lot of these techniques have evolved, but we should always, recognize our predecessors and mentors as the folks who have taught us how to do these surgeries and how to manage these difficult diseases. Something that is of interest historically has to do with the evolution of how we treat tumors nowadays compared to how it was 30 or 40 years ago. And there was one quotation from a paper that was commonly cited as the reason why patients always had to have surgery for these paraganglioma tumors in the head and neck. And it said, while there is clinical support for radiotherapy or radiation as the primary modality of treatment, we do not now believe that such a position has a firm histologic basis. In other words, they looked at irradiated tumors under the microscope and said these cells are still alive, they're still viable. And so how could it be true that radiation works? What we know now is that surgical approaches have evolved considerably. This photograph on the left is just an example of how many monitoring electrodes we place in the muscles of the face and the neck and the tongue and all the muscles innervated by the cranial nerves close by when we're doing these operations. And we have these modern microscopes and endoscopes and navigation systems that really help make these procedures a lot safer. And since about 1990 or so, patients have been treated with modern radiation delivery devices, such as stereotactic radiosurgery using the Gamma knife or Cyber knife or Linac-based systems. And just in the literature alone, there have been over 600 patients reported since the early 2000s. And as you can see in this table here, the tumor control rate approaches 100%. And so clearly, we've evolved in our understanding of these tumors and which ones require treatment and what treatment approaches we have available to us. So today, we're going to focus primarily on jugular and vagal paragangliomas, or glomus jugulare and glomus vagali tumors. A lot of this will cross over into carotid body tumors, and as you all know, carotid body tumors are a very common head and neck paraganglioma, so I don't want to leave that out. Though in the interest of time, we'll focus on the ones that really involve the skull base. Though you will realize that a lot of what we talk about today will apply to carotid body tumors as well. So again, as many of you are probably familiar with, the process begins really with a history and examination with a neurologist or a head and neck surgeon, depending on what type of tumor we're talking about. And that may be prompted by symptoms that a primary care physician or a general otolaryngologist identifies. And then ultimately, imaging is the first step and usually consists of an MRI. We often get a CT scan to look at the bone around the ear called the temporal bone to characterize the anatomy, particularly of the facial nerve as it pertains to the tumor and of the inner ear structures. And that provides us with a surgical roadmap when it comes to doing approaches through the ear or behind the ear to get to these tumors. Laboratory tests are absolutely vital in management of head and neck paragangliomas. It's quite rare for these tumors to be secreting or functional, meaning that they make catecholamines that can cause hypertension or high blood pressure, sweating, flushing, things like that. But if catecholamine excess is identified, that warrants further evaluation. And then genetic workup, and that's something that's also evolved over the years. Even for a sporadic tumor nowadays, sporadic meaning not associated with a known syndrome, we still recommend a genetics consultation, discussion of the value of genetic testing and how that may pertain to future generations and family planning and things like that. As I mentioned, whole body imaging, hypersecretion is something that prompts getting whole body imaging because it's so rare that head and neck paragangliomas secrete catecholamines. It's important to look for an occult pheochromocytoma if you do have catecholamine excess. And if one is not identified, then we assume that it's coming from a head and neck tumor. And then if an SDH mutation is identified, that also prompts whole body imaging to look for other sites of disease. And then at University of Utah and many of the centers across the country that employ a team-based approach, we really do emphasize shared decision-making for the treatment decision, and that starts with the patient and extends through the entirety of the team, including the surgeons, radiation oncologists, genetic counselors, speech language pathologists, and all others who may be involved on an ancillary basis with the management of a patient with a pheochromocytoma or paraganglioma. I do want to talk a little bit about the key elements of surgery for glomus jugulare tumors, and we'll talk about this for VAGAL tumors as well, as this is focused on the skull base. First off, I do recommend angiography and tumor embolization for all head and neck paragangliomas. Sometimes it's not possible technically to embolize the tumor, but I think the angiography alone helps us to characterize the vessels going to the tumor, around the tumor, and the veins that drain blood away from the inside of the head. And that usually occurs the day before an operation for a glomus jugulare tumor. On the day of the operation, we have continuous cranial nerve monitoring throughout, and that involves the facial and lower cranial nerves, or cranial nerves 9, 10, 11, and 12. And that's done by a dedicated neuromonitoring team. At our center, we involve an audiologist who has who has quite extensive experience in that area. And then we have a multi-surgeon team that's assembled for the more complex cases, and these individuals have become available on an a la carte basis or altogether for larger head and neck paragangliomas that require the expertise of everyone. And that involves a neurotologist like myself, a head and neck surgical oncologist, a neurosurgeon, a vascular surgeon typically. The approach to the tumor is what we call a transjugular approach or an infratemporal fossa approach, and often involves a transcervical approach to manage the blood vessels in the neck and identify the cranial nerves as they come out of the base of the skull. After surgery, patients usually spend a night in the neurosurgical ICU and 2 to 4 nights on the surgical floor, depending on the extent of surgery. Excuse me. The priorities for jugular paraganglioma really center on 4 things: cranial nerves, hearing, symptoms, and tumor control. And I don't think one of these is more important than any of the others, but we'll kind of unpack these one by one. The lower cranial nerves are the ones at highest risk by the tumor itself and by its treatment. And these nerves can either be kind of on the far side of the tumor or on the near side of the tumor. In other words, between the surgeon and the tumor, or the tumor can be between the surgeon and the nerves. And usually it's a combination of these things, but as you'll see in some later slides, some tumors primarily reside on one side or another, and that portends a different degree of risk during the operation to those nerves. These control voice, articulation, and swallowing. And I think, as some of you may have experienced, there's a difference between just having a vocal cord paralysis, for instance, from a cranial nerve 10 problem, and having post-treatment effects to that cranial nerve, or what's called a high vagal neuropathy. And so we really do look at that very closely before surgery as to what exactly is involved, which parts of that neural pathway are affected, if it's partial or complete, and use that in our approach, not only to the tumor, but to deciding what to do about it, whether it's surgery or a non-operative approach. This is an example just of a case that I've done recently where we did an intentional subtotal resection, or removing only part of the tumor to preserve the lower cranial nerves. And excuse me. This is the preoperative MRI scan, and this is the right ear. Here, just outlined in red, is kind of the epicenter of the tumor and the carotid artery in front of it. And here you can see, again, outlined in red, it's a slightly different type of MRI, but you can see where the residual tumor is located. And that was in an effort to protect the nerves on the inside of that jugular foramen, the medial side of it. And then after that surgery was completed, that patient fortunately did have normal lower cranial nerve function. And about 4 or 5 months later, we performed stereotactic radiosurgery for the residual tumor. Sometimes we will just observe that residual tumor and see whether it grows over time. This is a controversial topic, and something that has to do with the relatively unknown natural history of what the residual tumor does and what a tumor does to begin with, even if it's untreated. But that's something that is an active area of interest on a research front for me as well. The facial nerve is just as important. Generally, it's not affected by the tumor, but there are some cases where it is. It's more rarely affected. But it is very much at risk when you're doing the surgery to remove the tumor. And the approach that we take is something called the fallopian bridge technique, which is to leave the facial nerve in this bony canal. And I'm not sure if my mouse is showing up here, but we leave it in this bony canal here rather than taking it out of the bone and moving it anywhere, as the classic descriptions suggested. And while that's not wrong to do, it definitely provides better access to the tumor. Nowadays, with some more advanced instrumentation and visualization techniques, we're able to leave it in the bone most of the time. And that prevents weakness of the facial muscles after surgery. And if you ever have to go back into surgery for a recurrent tumor, though rare, the facial nerve is in a predictable location as opposed to embedded in scar tissue or grafts placed at the original operation. Hearing is also important. And what's really important to recognize about hearing is that glomus jugulare tumors can affect the hearing in varied ways. So their location, not just the size, influences the type of hearing loss and the prognosis for the hearing. Typically, if patients have sensorineural or inner ear type hearing loss, if whatever hearing loss is there is generally not recoverable with any intervention. And conductive hearing loss, on the other hand, which is a problem of getting sound from the outside world into the inner ear, may improve unless the surgical approach requires sacrifice of the ear canal. Radiation, fortunately, has a low chance of worsening hearing. What we found in a study I wrote in fellowship was that about 80% of patients maintain useful hearing in the ear 5 years after the surgery. I'm sorry, 5 years after radiation or radiosurgery. Pulsatile tinnitus, as some of you may have encountered, is a sensation of a pulsing or a noise in the ear. And that's treated primarily with surgery, but also may improve with radiation about 60% of the time. And if we do end up with a significant conductive hearing loss, but the inner ear is still good, then we can use bone conduction hearing devices to restore that function. This patient, for instance, had a glomus jugulare tumor, not a very large one, but had a substantial amount of the tumor in the middle ear space, the space behind the eardrum, and was quite involved with the bones of hearing called the ossicles. And she had pulsatile tinnitus, conductive hearing loss, fullness, and pain. And so we opted to remove the portion of the tumor that was in the middle ear space and in the bone around the ear. And for the residual amount of the tumor next to the lower cranial nerves, we performed postoperative stereotactic radiation. And I'm not sure how many of you are familiar with audiograms or hearing testing. Maybe you've seen some of your own over time, but what this one on the left shows preoperatively is a large conductive hearing loss with some inner ear hearing loss here in the higher frequency range. And this is how well sound gets into from the outside world, which is around the severe hearing loss range. And then after surgery, after removal of the tumor and reconstruction of those bones of hearing, we're up into the mild to moderate hearing loss range. Primary radiosurgery has become the preferred option at a lot of centers for glomus jugulare tumors. And the reason is to avoid the morbidity of the surgery to remove the tumor. And in a study of about 60 patients who had long-term MRI studies, what we found was that over a median follow-up of 5.5 years, meaning some patients did have follow-up up to 10 and 15 years afterward, there were only 5 cases where the tumor continued to grow on imaging after radiotherapy. And of all those cases, there was only one clinical failure. And what a clinical failure is defined as in our study was a patient who had radiation and had to have surgery afterward to control the tumor. And so having one clinical failure out of 60 over that period of time is pretty good odds. And at 5 and 10 years out from radiosurgery, the tumor control rates are about 98 to 94%. So based on what I've just said, it brings up the natural question of surgery versus radiation. And the main questions that I want to know and what steer me in one direction or another is, number one, symptoms and pre-treatment cranial nerve function. So if a patient has pulsatile tinnitus and has a high vagal neuropathy or a speech and swallowing dysfunction created by the tumor, then I generally favor surgery because I know that I'm going to make the pulsatile tinnitus better, and it offers the most definitive way of controlling the tumor and not having to worry about progression and potential involvement of other nerves or the intracranial space. On the other hand, if somebody has minimal symptoms or no symptoms at all and has normal lower cranial nerve function, provided that the tumor isn't very, very large, we generally opt for primary radiosurgery. The second question is whether there is intracranial disease. So this MRI scan at the top right shows a glomus jugulare tumor with a lot of intracranial disease here, right up against the brain. And while that's not an absolute contraindication to radiosurgery, it does involve radiation of the area of the brain that is directly opposed to the tumor. In other words, you can't just have the radiation go to the edge of the tumor and then have no radiation go to the surrounding brain. So that can have some adverse effects. Usually they're mild, but I do get a little more concerned about having to deliver radiation to that area for fear that could create swelling in the brain. The overall size and location also influence this. So this bottom right MRI scan, this shows the vein that goes around the ear called the sigmoid sinus and then down into the jugular bulb area. And this patient's tumor is almost all in front of that, which means that it's all on the far side of those nerves. And so to even take out 5% of the tumor would require working around or really through those nerves and probably sacrificing them or at least creating long-term dysfunction. If the tumor is in a more favorable location on the outside of those nerves or closer to the surgeon, then it generally suggests that it'll be safer to the lower cranial nerves. Growth rate is something that we're not always privy to ahead of the treatment decision. because relatively few of these tumors are observed over time. In contrast, glomus vagale tumors are frequently observed, and we know that the growth rate is relatively slow. But if a tumor is growing rapidly, I may opt for surgery. If a tumor is growing very slowly or seems rather indolent, then either continued observation or radiation is reasonable. Excuse me. Patient age and overall health, of course, play into the decision, just like with any surgery, and then whether the tumor is sporadic, occurring in one location, or familial, associated with an SDH mutation. Just to highlight some of the ongoing questions we have about observation and the natural history of these tumors and why it's an area of research interest for me. We have a patient here who's 65 years old, has normal cranial nerve function, and lost the hearing in her left ear about 20 years ago, which I won't go into too much detail, but I do think is related to the tumor. So one could say, well, that tumor's probably been there for 20 years. And over that whole period of time, she hasn't developed any lower cranial neuropathy. So what will happen in a case like this? Will it continue to grow? Will it stay about the same size? Will the cranial nerve still be fine forever and ever? And really, nobody knows. So with that, I want to move on to vagal paragangliomas, as I know that probably more of you have vagal tumors than glomus jugulare tumors. And I just want to echo what I mentioned earlier about having a multi-surgeon operative team. This was a quotation from Jim Netterville's paper. He's one of the foremost glomus vagale surgeons in the country. And what he said was, a skull-based operative team consisting of an otologist, head and neck surgeon, vascular surgeon, neurosurgeon should be assembled and be available should it become necessary. And so even for these tumors that are primarily in the neck and just below the base of the skull, they are quite involved, and the surgical approach and management of the surrounding blood vessels and nerves requires the expertise of multiple individuals. When to intervene for a vagal tumor is in some ways a little bit more straightforward, and primarily takes into account the status of the vagus nerve. If the vagus nerve is still functional, we do our best to observe these over a period of time or treat them non-operatively, like with radiation. And if the vagus nerve is dysfunctional and the tumor is enlarging or large to begin with, then we often opt for surgery for tumor control. And then whether they're unilateral or bilateral, it's more common to have bilateral vagal paragangliomas than it is to have bilateral jugular paragangliomas. And so we have to take into account the status of both vagus nerves, and if the surgery is done and that results in dysfunction of one vagus nerve, you have to have a good plan going forward for the other one, because bilateral vagal neuropathies is a very bad problem. So radiation is effective. Based on the location, it may require a different treatment schedule. Stereotactic radiosurgery for glomus jugulare tumors can often be carried out in 1 or 3 to 5 sessions, depending on the instrument. Vagal paragangliomas sometimes can be treated in a similar way, but may require more conventional fractionated schemes where it occurs over a 4 to 6 week period. Key elements for surgery are very similar to what they are for glomus jugulare, so we won't go into a lot of detail, but the main things that are different is that the approach is primarily through the neck and secondarily through the ear if the tumor goes quite high. And all patients should have a speech and swallowing evaluation afterward, as there is some degree of a vagus nerve or vagal neuropathy after the surgery, no matter what their pre-existing function was. The priorities primarily center on cranial nerves and tumor control because the hearing is not really at risk. And symptoms tend to be milder, though pain can be a symptom given the location of the tumor and sensory nerves in that region. The approach is determined by the location and the size. And to cite Dr. Netterville again, there are 3 classifications, A, B, and C. A being ones in the neck only, B are those up to in contact with the jugular foramen, and then C being into the jugular foramen, plus or minus having extent intracranially. Generally, we take a purely transcervical or through the neck approach for the type A and some of the type B tumors, and a transcervical and transmastoid or a transtemporal approach for some of the, or for most of the B type tumors and all C type tumors. How does SDH mutation influence all of this? And many of you probably know your own genetic mutation if you have one, and based on your families, know about the inheritance pattern and things like that. But really the main thing that I want to highlight here that influences our treatment approach is the risk of malignancy being highest in patients with SDHB type mutations. And SDHA, while quite rare, in contrast, does have a high malignancy risk as well. And this was a table taken from our own David Taib, who is also involved in the Pheo Para Alliance. And how does that risk of malignancy actually play in, and how do we predict it? And the truth is that we don't have a gold standard test to determine whether somebody has a malignant tumor or not prior to intervention, unless there is clear evidence on imaging of involvement of lymph nodes or distant other organs. But there are some emerging biochemical and histopathologic features, such as the Ki-67 index and others, that can be analyzed once a tumor is removed to determine whether it seems to be on the benign or malignant end of the spectrum. Ultimately, it's whether it's in lymph nodes or a distant site that defines malignancy. It turns out size doesn't really matter in head and neck paragangliomas as to whether it's malignant or not. A very large one doesn't necessarily have a higher risk of malignancy. This is not true in pheochromocytoma, though that's not my area. It seems to be that larger pheochromocytomas have a higher risk of malignancy. Highly infiltrative tumors, we think, may predict a malignant potential. So tumors that have involved surrounding structures, soft tissue, nerves, nerves that generally aren't affected by glomus jugulare tumors. So generally not lower cranial nerves, but facial nerves or nerves that go to the eye. And every time I do a glomus jugulare operation, I do sample lymph nodes in the neck at the time of surgery, even if they're negative on imaging, because sometimes you'll find a micrometastasis or a very, very small focus of tumor in the lymph node that will change the diagnosis from a benign to a malignant head and neck paraganglioma. And then for SDHB mutated patients, we generally favor earlier intervention because of that risk of malignancy, as there is some evidence, mostly anecdotal, to say that the earlier you intervene, potentially you can mitigate that risk of malignant spread into other sites. Lastly, I want to talk about hypersecretion, and what that means again is catecholamine excess or tumors that are functional and producing hormone. And generally for secreting tumors in the head and neck, we favor surgery, of course, with adequate adrenergic blockade or medications that block the effects of those catecholamines so that surgery can be safe. But sometimes radiosurgery can be effective as well. And in this very small series of 2 cases and a review of the literature that we published several years ago, this patient had pre-op catecholamine excess. Even after surgery, had significant catecholamine excess above the upper limit of normal. That slowly crawled up over the ensuing few years. And then the patient had gamma knife radiosurgery, and then that catecholamine excess came down into the normal range over a few years. And 10 years after radiosurgery remained in the normal range. So we do think that it can be effective. It's absolutely vital to have an endocrinologist involved for perioperative management. And as I mentioned before, because of how rare it is for a head and neck tumor to secrete hormone, it's important to look for an occult pheochromocytoma. So with that, I think I've taken a little more than 30 minutes, and I just wanted to thank everybody for joining us today. And I think at this point, Amy, I'll end my sharing, my screen sharing, and open it up to questions here.
Great. One of the first questions that we got, and I think it's a good one to start with, is a patient who is interested in everything that you want to share about the subject. Particularly, they want to know how you became interested in head and neck paraganglioma tumors.
So it's funny how your interest in a certain area kind of develops from a combination of things over the years. And it was always of clinical interest to me. In neurotology, paragangliomas are one of the kind of index surgical cases or tumor types that we manage that kind of fall into our domain. Neurotology is a very, very small specialty, and the tumor types that we manage are really quite limited. And glomus jugulare tumors are really the domain of a neurotologist. So I became clinically interested in those based on the surgical approach and how challenging it is to manage them. And then I was fortunate to be at a center where we had an extensive experience treating paraganglioma tumors, not just with surgery, but also with radiosurgery as well. And that led me to working on those several publications about gamma knife radiosurgery and jugular paragangliomas. And then, so that gave me kind of the clinical and research sides. And I found that it was easy for me to study those subjects, and it was easy for me to complete those research projects. And so I said, well, it must mean that I'm interested in this. And fortunately, I ended up at University of Utah, which has a long legacy of treating not just SDH mutation patients, but also sporadic paragangliomas, being a large referral center in the Intermountain West. And that has continued to kind of create a snowball effect with my early clinical and research interests, and something I hope to cultivate down the road. I don't have a personal story or a family member or something like that that influenced me, but I'm sure that I'll collect those along the way.
That's great. Thank you for sharing that with us. From our chat session, we have a question. Any advice for patients on how to best support communication amongst their specialists, endocrinologists, surgery, radiologists in the shared decision-making model for treatment decisions?
So this is really, this is a great question, and it's quite center dependent as to how those communications occur. I think, one example is our center, where we have a multidisciplinary tumor board that meets a couple times a month to discuss just paraganglioma and pheochromocytoma cases. And then separate from that, also a head and neck tumor board and a neuro-oncology tumor board. And so there are multiple avenues for specialists to get together, look at imaging, look at case histories together, and have a discussion. And I think that's something that most centers are working toward developing, as a collaboration on those fronts. And that's really the best way to communicate, is to get everybody in the same room, whether it's physically or virtually, talking about cases. How to do that, from the ground level, from the patient level, is definitely harder. But be firm and encourage your specialist, whoever seems to be quarterbacking your case, to gather input from other specialists to whatever degree they feel is necessary or appropriate, and return those recommendations to you. And I think, just advocating for yourself in those conversations is the best thing you can do, understanding that many centers still don't have a tumor board like that, or a multidisciplinary discussion going on. But it's something to inquire about as well. Most places that have a neurotologist, a vascular surgeon, a neurosurgeon, a head and neck surgeon, a genetic counselor, all involved in the care, probably have some mechanism to meet on a periodic basis.
Okay. And is there anything in particular, a particular approach or language or information that a patient can have on hand to sort of spearhead that, or make their process easier?
Yeah, I think as long as you have good knowledge of some of the things that I've brought up in the talk today, mutation status, whether you have a sporadic tumor, familial tumor, what specific SDH mutation it is, if you have one, where the tumor sites are, the cranial nerve status. You can provide those things as a bit of a clinical background and frame your questions accordingly. Hopefully, with the increased adoption of telemedicine, we'll have the opportunity to do not just one-to-one virtual visits with patients and providers, but maybe ones where 3 different providers join into a Zoom session and with a patient and talk about things that way. I imagine that we'll get to that point at some point. As you all know, as patients, it's hard to get everybody in the same room on the same day, have even appointments on the same day. But I don't think there's any magic word that you can say. But as you probably all are, just being educated about your own diagnosis and being able to present those things in a cohesive way to treating providers is probably the best thing you can do.
Okay, we have another question, and I lost my thing because my battery's getting low. Do inherited paragangliomas skip generations?
Generally not. What makes it seem like sometimes they skip generations is how severe the disease manifestations are in each generation. So just because, say, a parent of a child, both affected by the same SDH mutation, have that mutation, doesn't mean that they will have the same sites of disease and the same manifestations of disease. So when we screen younger generations for paraganglioma or pheochromocytoma tumors, sometimes you don't find anything. And it's a bit of a head scratcher to a parent who says, well, I was diagnosed when I was 20, and now that my son or daughter is 20 and they don't seem to have any, are we missing something? Is there something hidden somewhere? And it just doesn't show up the same way in every generation, even if the mutation itself is carried through.
Okay, thank you for that answer. Another from our chat session: when you say early intervention for SDHB with regards to malignancy risk, does early refer to tumor size or something else? Should neck lymph nodes be checked even if glomus vagale is not removed surgically?
That's a great question. There's no, to the latter part of the question, there's no guidance that I'm aware of in the literature about whether somebody should have what's called a neck dissection or removal of lymph nodes to diagnose malignant spread into neighboring lymph nodes. I would rely on imaging for that. If nothing is seen on imaging and the tumor is being observed, and over serial imaging, we don't see enlargement of lymph nodes in the region, then I wouldn't think that they would have metastatic disease harbored inside the lymph node. And then as far as early intervention, that has to be taken with a little bit of a grain of salt. And I realize that it was a bit of a general statement, but certainly if somebody has a small glomus vagale and no cranial neuropathy, I wouldn't say you have to go after it right away. But if it is enlarging quickly, then I would favor intervention. And the other tricky part of it is what happens if you choose a non-operative route. So if you treat it with radiation instead, because you still have a functioning vagus nerve on that side, does that change the risk of malignant spread into other sites? And to my knowledge, that's not known. And so that would be a more nuanced decision with your treating provider or surgeon. But to summarize what I said about early intervention or early treatment, if a tumor is enlarging over time and you have an SDHB mutation, then after a comprehensive discussion of risks and pros and cons of intervention and close review of the imaging to see whether there is any evidence of metastatic disease or not, generally I would favor upfront treatment.
Okay. Can you comment on appropriate follow-up for tumors that have been removed that do have a genetic mutation like SDHB or SDHD, and then tumors that don't have a known genetic mutation that have been removed? Is there a difference in the follow-ups that you would recommend in those two cases?
Definitely. For patients with SDH mutations, we generally maintain about the same frequency of imaging over time. While it's usually annual, we sometimes will stretch it out to every 2 years if somebody is doing really well and has no evidence of progression or new sites of disease. For a sporadic tumor that has been removed, the first question is, was it completely removed, or is there any evidence of residual tumor left behind? And if by the surgical description, it was completely removed, and on the immediate postoperative imaging, it appears that indeed there was no tumor left behind, then that imaging interval can be spaced out. So to give you specific numbers of my own practice, without getting into a ton of detail in every possible situation, but for a complete resection of a glomus jugulare tumor, for instance, I usually get an MRI at 3 months after the surgery. If the tumor is completely removed and I don't see any evidence of disease on the 3-month MRI, then it'll be annual for a few years, then every 2 years for a few scans, then every 3 years, every 5 years, and space it out from there. For one that has a residual tumor left behind, it depends on whether we treat that with radiation or whether we're going to observe it as to what the imaging schedule is.
Okay, great. And I have another kind of related question. Can you give any information on the success rate of surgery to remove a para following the failure of radiation?
Yeah, this is a question we've all kind of asked ourselves also. To my knowledge, there's no published larger series of post-radiation surgical salvage, is what we would call it. But what I can comment on is that the reason why people have adopted radiation relatively readily over the last 10 or 20 years is that it doesn't seem to make the surgery considerably more difficult. It's already a relatively difficult surgery, but in contrast to other benign intracranial tumors like schwannomas and meningiomas, in those cases, it is much more difficult after radiation to preserve surrounding cranial nerves and to remove the tumor from all the critical structures. In glomus jugulare tumors, it doesn't really seem to have that effect. And some people even say that it can be a little bit easier because a lot of the blood vessels in the tumor have still been affected by the radiation and are no longer flowing. And so it becomes a surgery with a little bit less blood loss concern. That being said, most cases of salvage surgery that I've either been a part of or have read about involve patients who have had a progressive tumor with cranial nerve involvement, either at the outset or after the treatment at some point in time. So the removal can be a little bit more radical or a little bit more aggressive because you certainly don't want to have to retreat it again after that. And in those cases, if it were my patient or my case, I would say that the salvage surgery would be quite successful, but it doesn't mean that you can just ignore it from that point on. You'd still have to have periodic surveillance scans and then monitoring, of course, for spread, like malignant spread, because clearly something that has recurred after radiation to the point where surgery is required or recommended usually suggests that the tumor is a bit of a bad actor.
Okay, thank you for that. Another from our chat, is there any guidance on expectation for rate of tumor size reduction over time following stereotactic radiosurgery, specifically glomus vehicle with, I think they meant VAGAL, with SDHB?
The general answer to that is that stereotactic radiosurgery and radiation for skull-based paragangliomas generally doesn't create a lot of tumor regression or shrinking over time. Sometimes we do observe that, as a lot of these tumors is composed of blood vessels, and the blood vessels may shrink up over time, and then the overall volume of the tumor gets a little bit smaller, but that's relatively finite. We don't see progressive death of those cells over time where it goes from being 3 centimeters to 2.8 to 2.6 to 2.4 over time. And so tumor stability is really what we're looking for. So if somebody is choosing to go the route of radiation or radiosurgery, the conversation I have with them usually doesn't center on, let's treat you so that you can be cured of the tumor and it's gone and we're not looking at it on a scan. What I usually say to patients is, a success would be you and I sitting here 10 years from now, looking at an MRI scan that looks exactly the same as the one we have today.
Okay. Another that was submitted beforehand, generally, it actually has to do with carotid body tumor, which I know you didn't present on today, but I wonder if you could comment. At what point would you recommend generally surgery over surveillance? When would the scales tip for you with an SDHB mutation in the mix in particular to opt for surgery instead of just a watch and wait approach?
Yeah, so there really is no size cutoff or size determination. If generally speaking, and again, carotid body tumors are broadly speaking in my area of expertise, but fall mostly under the head and neck surgeons that I work with. So I want to give you an accurate view of things, but it's not my specific area of practice. But I will say, carotid body tumors come in different degrees of involvement of the surrounding vessels, so the carotid artery, and the classification we use is called a Shamblin classification. And if we see that a tumor is growing in such a way that it's involving more and more of that carotid artery over time, that may be one where I would opt for intervention, because I would know that over time, we're going to have a lot of trouble with that vessel, and it's going to require a graft or something like that. And especially as a patient gets older, reliance on the carotid artery on the other side and the connections between the circulation from the left side to the right side and vice versa that occur inside the brain get less and less reliable because of plaques that build up in arteries and things like that. So it really has to do, if a tumor is under observation, it really has to do with what is happening to it over time. Is it growing in a way that isn't really changing much of the surgical risk, or is it growing in a way that is changing the surgical risk? How does it look compared to the surrounding structures? And are we seeing any evidence of concerning lymph nodes around the tumor? Again, those malignant spread cases are quite rare, but in an SDHB mutation is something we have to consider. But those are some of the points that I would raise with my treating provider if I were in that situation.
Okay. And another from our chat, and I think perhaps for timing, we'll see, this might be our last one. Do you consider the age of the patient when deciding radiosurgery versus cold surgery? For example, a risk of radiation for a younger female patient who might be considering getting pregnant at some point?
Yeah, so age is always a big consideration for radiosurgery, because the longer the tumor is still there, the longer we have to worry about it. And our data doesn't go back 50 years because radiosurgery just hasn't been around for 50 years. From what we know from approaching 20 years of data is that it is still effective even at long term, but we do start to see some late failures. And by failures, we mean something doesn't turn on a dime, but it reaches the threshold where the tumor is definitively grown from the time of radiation treatment. So in our series, there were a few patients who encountered that about 15 years after their radiosurgery treatment. But in all those cases, it didn't necessarily require a surgical intervention. So there are some really rare cases of, and these are individual case reports over time, where radiation has led to conversion into a malignancy. The question in those cases is always, was it a malignant tumor to begin with? So I don't usually take into account that risk when determining whether or not to use radiosurgery. In other words, I'm willing to apply radiosurgery in a patient with an SDHB mutation. So because of the fact that we don't think radiation, and this isn't true of neck tumors, but of base of skull tumors like glomus jugulare tumors, severely affects your ability to remove the tumor later on if it's required. Age is less of a player than it is for other types of tumors that we radiate, and particularly those in the neck, where you generate a lot more scarring around the tumor, and it makes it more difficult to remove from surrounding nerves in the vessels. Radiation, we also know, can cause some narrowing and thickening of the vessel wall in the carotid artery. We don't really see that problem occur at the base of the skull, but that does seem to happen in the neck. And so all those things can come into the discussion and should be points that you bring up with your treating physician.
Thank you, Dr. Patel. I think we'll close on that note. We do want to thank you for your time and your dedication to our patient community, and we're very glad to have you on the Medical Advisory Board for the Pheo Alliance. This webinar will be available in a few days on YouTube and on the website, and we will also transcribe the Q&A portion and have that available. You can sign up for our e-newsletter and follow us on social media. If this information has been useful to you and you'd like to donate, you can do so at pheopara.org/donate. Again, special thanks to Progenics for making this webinar series possible through an educational grant. And a thank you to everyone who attended today.
Thank you.
Thank you. Thanks for your time today, Dr.